Okay, well, good morning, everyone. I hope it's morning for most of you, or good day, let's say. Today, we're gonna present the plan evaluation, and we're gonna explain a method that is being called the perfect method to evaluate a plan. We hope at the end of the presentation, we can all agree that it's perfect. And you can always make it even more perfect in your institution, which is called the CV CHOP. And the CV CHOP will learn in a little bit what it means each letter. So with me, I have Dr. Nauman Malik, who is an assistant professor at the Princess Margaret Cancer Center in Canada, and also Dr. Amir Safavi, who is a clinical fellow at Memorial Sloan Kettering. And I'm also a medical physicist at Memorial Sloan Kettering Cancer Center. So I'm going to be going through the presentation, but also Nauman is going to be giving the physician point of view of all, of each section. So CV CHOP, what does it mean? So it's an acronym for letters, and it basically gives you the sequence, let's say, of how do you evaluate a plan. Starting with the C, which is contours, then you go to the beams, and then you go through the coverage, heterogeneity, organs at risk, and then finally the prescription. So basically, these methods has been, you can see the publication here, and it has been widely used for many physicians in general to evaluate a plan. If we start with the letter C, which is contours, and again, there is no way that we can tell you everything that you need to check on a plan, but these are the most important things that you should not forget to check when you're going through a plan evaluation. So one of the most important things is that you ask yourself the question if all the GTVs, primary, nodal, pre-op, contoured, have been contoured. So you need to make sure that we are certain that everything that needs to be treated, it is contoured. And you can always, as usual, use additional imaging to basically review the contours. So also another question that
I just wanted to add for that.
Yes, of course.
Thank you. When you are contouring in all three planes, it's really important in head and neck to make sure that the contours align and make sense in all three planes. So the coronal, the sagittal, and the axial, the anatomy has to all make sense. And sometimes if a tumor, for example, is arising from a tonsil and it is extending and going into the soft palate, it has to look a certain way on the coronal and sagittal as well for you to convince yourself this is the route of spread and extent. Because if it doesn't make sense, if you contour something and you're going across the air, like if something is a base of tongue, arising in the base of tongue, and it's confined to the base of tongue, and you look at the sagittal and you see that you've contoured part of the soft palate, and so then you would know, okay, maybe I've gone a little bit too high, and that doesn't make sense in terms of the route of spread for this cancer because I know it's confined to base of tongue. And sometimes the only way you can tell that is by looking at the sagittal and coronal, not just the axial. So just very important to do that as well.
Excellent. Thank you, Nauman. After we are okay with all the contours, and so basically, you know that we create expansion to create basically all GTV. So making sure that all the expansion and all GTV to create the extra target volumes are correct. You can see on the pictures here how this is, again, this is only coronal views here, but as Nauman says, you need to check also the expansions in all the cuts and in all the views, in axial and sagittal, because sometimes, depending on how you create it in the treatment planning systems, if you do a 3D expansion, if you do a 2D expansion, things might get weird and can include things that you do not want to include in the other cuts. So also, for example, we know that we are not only doing contouring targets, so they are basically ORs and other organs at risk of normal tissue around. So making sure that all the anatomical boundaries are respected is a thing that you need to check. And basically, it's very common in head and neck that we're going to have different prescription dose levels. So you want to make sure that the expansion for each GTV of one prescription level correspond to the others, to the CTV and PTV of that prescription level, making sure you don't mix up prescription level expansion. So, and like here you can see how many colors we have. That means how many maybe different type of dose levels. So you need to make sure that everything is good.
One
Anything?
clinical concept I want to talk about in this section of contours as well is for those individuals who contour a microscopic or subclinical dose volume, for example, a CTV 56 or a CTV 50 on top of growth disease, it's important to think about the routes of spread. So as Dr. Malik said, not just the anatomic boundaries, but areas that you could anticipate the cancer beginning to spread to. So for example, if it is a bulky tonsillar cancer, you're thinking about potential expansion towards the retromolar trigone, you're thinking about extension up the pterygomandibular raphe, up into the pterygoid plates. If it's a base of tongue tumor, you're thinking about making sure that if it's a bulkier tumor, you have adequate coverage of the pre-epiglottic space. And so these are areas that when you're reviewing contours of yourself or a peer, you want to make sure that these areas are well covered if you're putting on that microscopic volume CTV.
Perfect. Thank you so much, Amir. This is a very busy slice, but actually we talked a little bit before that we don't only have targets, we have organs at risk. So basically you have to make sure that you delineate it correctly. So here there's some instructions or some ways that the most important, I don't want to say most important, but the most popular organ at risk that we have for head and neck, like the spinal cord, the esophagus, the optics, the oral cavity, some tips on how to contour, for example, for the core. There shouldn't be a gap between the core and the brain stem. It's very important, actually, that for the physics point of view too, that we know when we plan and we optimize on these two, on the structures between that they are adjacent. So if you leave a gap, the treatment planning system may add a hotspot or like a weird thing in between. So you want to do a smooth transition between structures that they do meet in a way. Like, for example, a spinal cord with the brainstem. Also, for example, the optics, like the optic chiasm, you join them in a way to the optic nerves. I mean, sometimes it's not real, but you know that they join. So you want to have a smooth and overlap in between, and there is not a gap, because they can be weird things when you optimize, and you need to evaluate very careful. And then, of course, here you have a list of a lot of the structures that you might find and you mustn't contour in a head and neck treatment, because we do have constraints that we need to respect for all of them. So it's very important that you do a good review when you delineate it. Anything to add, Amir? No.
Yeah, go ahead, Dr. Malik.
Just to add that, when you get to the part when you are evaluating the plan, oftentimes, different OARs will be drivers of where the dose is going, and they all have kind of different priorities in how much you want to spare each of them. So, the brainstem and spinal cord are always going to be very high priority, whereas sometimes, you may, and when we get to the plan, we will emphasize this, certain OARs you will expect that you may not be able to kind of meet the constraints as well, and they will get more dose depending on the type of plan. So, contouring them accurately, especially around the target where the tumor is very important, because how accurately you contour the OARs determines the quality of the plan that you will get and how well the optimizer functions in the end.
I completely agree with Dr. Malik. I think there are a couple OARs that there are always some controversy about how to well contour. And there has been a recent, thread on Twitter that substantiates some of my peculiarities. For example, with the parotid glands, often there's some debate about how anterior you should contour them, whether you should begin to include some of the ducts. With the oral cavity contour, sometimes the floor of the mouth is missed. And so you want to be careful about these structures because, as Dr. Malik said, if they're not contoured and optimized to, you can't improve the planning to improve the side effect. And so you always want to interrogate these closely, even though they're just organs at risk.
Excellent. And you know better than me, you, Amir and Nauman, but there are a lot of good atlases that you can refer to for contouring, especially ORs, but targets too. So they are accessible in general to everyone. So I know RTOG has good atlases and you can learn how to do that. Okay, so moving to the next slides, we have our first poll question. The question is, why do we check contours in axial, coronal, and sagittal planes during radiotherapy planning? And the options are to ensure, A is to ensure accurate localization of the tumor and surrounding structures. B, to confirm the dose distribution across different planes. C, to verify the synchronization of treatment beams. And D, to reduce potential motion artifacts during the treatment. So we're going to give a couple of seconds, maybe a minute, not seconds. And we have the yes, perfect. So far, we have 52% of the participants responding. We're going to give a couple of more time. We can probably get hopefully to 70%, I guess. We'll still in the 50s, so I encourage people to, read the question and answer. Again, here, this is not an exam, so we're all learning. So just answer what you think is most appropriate, of course. Okay, so it has kind of plateaued a little bit, so we're in the 60%. That's okay. So I'm going to end the poll, and the results, 84% respond that A is the correct answer, and that's correct. That's the correct answer. Why we contour in axial, coronal, and sagittal, Nauman said, is to ensure accurate localization of the tumor and the surrounding structures. Very important to verify in all the cuts and all in a 3D view when we contour. Okay, so now we're going to move to the B of the CV shop methods, which is beams. So basically here is when you pause a second. I mean, you know that the planners, dosimeters, or medical physicists are going to be in charge of selecting the most appropriate beams to deliver the radiation to the patient. And normally in many institutions, what I found is for many anatomical sites, you already have like a standard set of beams arrangement that you normally use. So you will see, okay, we always start with this, and then if we need to make some adaptation because of the targets of avoiding certain things, we might tweak them a little bit. But it's always good to develop some like a starting point for beams. That's always help. And here we have some suggestions actually of 7 to 9 IMRT fields is normally a good distribution if we're talking about IMRT static fields, dynamic fields, sorry, but static gantry. And one very important thing that you need to think is in the head and neck treatment, we have the shoulders in between. So we wanna, and the shoulders position, normally they're very well immobilized with the fine point mass or something, you know, but there is always a wiggle of the patient that can do in the shoulders. And imagine if you have beams going through the shoulders, there is it could be a big change in the path of the beam, so of distance, and that will definitely significantly change the dose distribution in that area. So we want to avoid as much as possible entering through the shoulders for fixed beam IMRT cases. And here again, if it's a 7 dose distribution, again, this is a suggestion. It's 7 posterior field. It's been found that it's worked very well, but sometimes there can be modification depending on if you have the gross tumor disease is very anterior, for example, for an oral cavity or nasopharynx cases, you might want to move some of the posterior arcs to make them anterior, even to have 2 or 4 anterior field. Again, you can be very creative with the beam arrangement. My only advice is actually try to have a standard so everybody follows the same. So, and then for plan evaluation, it will be easy. So as a physician, when you're reviewing the plan, you need to think about, you want to make sure, okay, the beam arrangement makes sense, follow the standards we have more or less, maybe there is a little variation, but very important to avoid the shoulders. That is if we talk about IMRT. If we talk about VMAT, which is something that is being used very, more commonly now, late in these days, 2 to 4 arcs is ideal. Again, also when you do beams, think about the therapies, because yes, you can always have a plan with like 25 beams, which is beautiful. Maybe you get it very conformal, but actually think about the therapies and the treatment time and the position and all that. So you don't want to have very limited number of fields, but you don't want to put a lot of fields or arcs, because it could complicate the delivery. They give a good plan, and then in most cases, for most complications, you will go to 4 arcs. And here you can see also it's a good trick to also play with your collimator angle in order to basically make sure that when the leaves move, they're gonna move in a way that you're gonna be helping the optimizer to not to suffer too much. Remember, for head and neck, we have a lot of organ at risk that we need to protect. So basically, the way that the leaves move is the direction that they move. It could impact, or it could make easier the optimization process. Here, the suggested collimator, normally we like to have, if it's 2 arc, we do it at 20 degrees plus minus, so in the different position, and that actually it helps with the leakage between the fields. Imagine if you have all the arcs with 0 collimator arcers, you are basically promoting to have a little more problem with the leakage, the leakage between the leaves, which is, it's being taken into account in most treatment planning system, but it's also a good idea to think about that. Any contribution, Amir or Nauman?
No, I think that's great. I have nothing to add for this. Amir?
Okay.
Likewise.
And here I have even, again, when you do these 2 full arcs, actually, you're going to go through the shoulder. So the most important thing here, we always have the concept of avoiding the shoulder. So you're going to be using the shoulders in your optimization device as a avoidance structure. You can do 2 things. Most treatment planning systems, you can contour the shoulders and avoid them, create it as an avoidance structure, or you can avoid the sectors. When the beams are going to start passing through the shoulder, you can avoid that sector, and then it continues after it passes the shoulder. So it depends what is your preference. There is no good or best and not best, but you choose whatever is better for you. But the most important thing, you need to avoid it. So if there is actually a little variation sometimes, if you don't use full arcs, you can also use the same concept that we were seeing with the MRT, that we avoid the shoulders just by closing the jaws sometimes for the beams that they're going to go through the shoulders. Here's the same. You can select full arcs above the shoulders, and these are full arcs because we're not going through the shoulders. And then you might select 2 more arcs. You can do it on the anterior aspect of the so they are like partial arcs, basically anterior partial arcs, to avoid the shoulder. Again, this is something that you will need to see how it works in your clinic, depending also in your immobilization device. If the shoulders are very well immobilized, you might clip them, but actually it's always a good idea to avoid them. So then we can move to the second poll question. And the question, what is the primary reason for avoiding beam entry through the shoulders in fixed beam IMRT plans? A, to prevent patient discomfort. B, to ensure accurate dose calculation. C, to reduce scatter radiation. D, to improve imaging quality. And the poll question is up. And again, we encourage everybody to answer. We're 50%. So let's try to at least get to 62%, which was the participation last in the previous question. And we're getting very close. All right, so very good. Thank you, everybody, for answering. I'm going to end the poll question. And basically 66% of the answers choose answer B, to ensure accurate dose calculation, which is the correct answer. We have some 30% that basically answered C, to reduce scatter radiation. That is also more related to the concept that I was saying about the collimator angle. Scatter radiation will come through the interleaves scatter or leakage, but also from, the machine, the head of the machine. So it's not quite correct. It's a good answer, but actually the correct answer is B, to ensure accurate dose calculation. Because remember, if you have the shoulders and you go through the shoulders and the shoulders move in between or change position, the depth of the path of the beams can vary from 5 cm to 10 cm, and you know that can contribute in a big difference in those calculation, in those distribution. I'm gonna end the poll. So now we're gonna move to the C, which is of the CV-CHOP method, which is coverage. And coverage actually, of course, is very important. We basically evaluate the coverage on targets 5 millimeters away from the skin in general. So for that, we can ask, because sometimes, some of the PTV with expansion, they can come very close to the skin level. So basically, and that we have the build-up region, and there are physical limitations to get 100% of those there, unless you add a bolus, but that's something that you need to ask the physician if it's needed. So we will always, the dosimeters will always create this PTV evaluation. It's good to do it, which is basically the PTV minus 5 millimeters from the skin. So that is something very important, because actually when you see the DVH, and the PTV is very close to the skin, you will see that the coverage is not as great as it should be, but that's not what we want to look. We want to look at the PTV with the 5 millimeters away from the skin. And you always need to make sure that the PTVs are covered with the 95% isodose line. And if it's not, you basically, you need to evaluate why this coverage is being compromised. So because there might be a reason, there might be, maybe the parodies are there, which you want to spare, or the core or anything that it can be basically they can influence. Like for example, here in the two images, on the images on the left, we have the basically the explanation of the PTV evaluation away 5 millimeters from the skin. And also, for example, on the right, we have a little, a dent on the coverage, but actually maybe because the mandible is there and you want to limit the dose to the mandible.
One thing I'll jump into comments about this concept of coverage and prioritizing OARs. I think in the early days of IMRT, there was some potential concern that by trying to prioritize OARs, like let's say the parotid, and push the dose and maybe compromise coverage a little bit at the lateral aspect of the target, that perhaps there could be a risk of increased recurrence and target miss. And I think with time, we have come to realize that this doesn't really happen. And in the late 2000s, Nancy Lee published a case series of parotid failures with IMRT. But when you look at the cases, in all of the cases, there were subtle nodes that were not detected at the time of the initial planning by the diagnostic radiologist or the team closely interrogating. And so I think the takeaway is that you can still prioritize limiting dose to your OARs and push the coverage a little bit to be safe, as long as you closely interrogate the diagnostic imaging and the clinical exam to make sure you do still cover gross disease and you're not missing subtle findings. So definitely still prioritize the OARs.
Excellent, thank you. And
Cesar,
yes.
we have one question. One way to avoid shoulders is during simulation trying to put the patient pulling a rope, especially for simulation.
Yes, that's correct. But there is so much that you can pull the shoulders down. So the shoulders, they are all, this is a good method. Actually, there is ropes, and just that actually is not, is a technique not to avoid the shoulder. It's just to make the shoulders more stable. So they are always will be in the same position, but you will always have targets on the way, if you look at the patient entry through the shoulder. So you need also, when you design your fields, to make sure you do avoid the shoulders to get the radiation to those targets that they are in between the shoulders, basically, and the entry. Yes, but it's a yes, it's a good question, because immobilization devices, as in any type, not only head and neck of treatment, is very, very important. You want to make sure that everything is reproducible. So, we basically always make sure that the review that the coverage makes sense and is acceptable. And as we explained, and Malik Nauman did a good concept on reviewing contours in every slice in the 3D plane. So also the coverage, you need to go and scroll through every slide, because things might happen. You may be, especially for head and neck, that we're avoiding so many critical organs. So the dose needs to go somewhere. So you might see beautiful coverage around where the parotids are, and then the moment that you exit the parotid and you go up, peaks of radiation might happen. So you need to make sure that you go through everything in slice when to see the isodose line. And you look for cold spots, or also hot spots, that they can be outside of the target or the ORs.
I wanted to add at this point, this is probably one of the most important slides, because as you build up your experience in doing plan reviews, you can look at the isodose lines and scroll through and figure out how the optimizer is functioning. If it's trying really hard to avoid certain OARs and pushing the dose in certain directions, you can visually look at the isodose lines and be able to tell where the optimizer is struggling. How can this plan be created in a different way to push dose in a different direction? Because ultimately the dose always has to go somewhere. The hot spots always have to go somewhere. The cold spots always have to go somewhere. And there's a question about that. So hot spots would be, areas that are above your prescription dose. Generally speaking, we can define them as above, like 105 or 10, depending on how much you want, like 105% or 107%. Colder spots are things that are, under coverage. So typically could be, depending on the center and what your practice is, can be less than 95. And so depending on where these areas are, they're always going to be somewhere in the plan. There's no way to not have them. And for you to be able to scroll through the plan and figure out where you want them, where they are, tells you how the optimizer is functioning, and where, if you wanted to edit your plan or make changes, having a good understanding of plan review and modifications will tell you what you can communicate with your planning team and tell them in terms of you can ease off of this structure and instead prioritize this, and that'll get you closer to the plan that you want.
Excellent.
Two comments I wanted to add as well on this topic. So one of them is around this concept of scrolling through to really see the variation from slice to slice potentially in the clinical target volume. So where Dr. Malik and I trained at Princess Margaret, the group is very meticulous about the contours being anatomically precise and smooth in 3 dimensions. And so when you look on coronal or sagittal, sometimes you may see some contouring where there can be this Christmas tree effect, where it can come in and out a little bit. And so this can have an implication for the plan evaluation as well. So if you're looking at just one slice or a few slices, it may not be fully representative. And so there could be slices where there is under coverage, where there are some inaccuracies in the interpolation or because of that variability in contouring. So scrolling through every slice makes sure that you are appropriately covering the true volume in 3 dimensions. The second, as Dr. Malik was saying about scrolling through to see how you can push the doses off of the organs at risk. One of our mentors, Dr. Arjun Sehgal, who's a CNS radiation oncologist, really helped to reinforce this idea to me of thinking of the dose distribution in 3 dimensions. So when scrolling through, not just looking at every slice discretely, but almost seeing the dose move like a movie, moving in real time, and trying to see, for example, if the dose is very loose in one area, if as you're scrolling through, it's too tight in one area, and you can rechange that distribution and push the dose and flow it in a different direction. So scrolling through to develop a 3-dimensional dynamic sense of the dose distribution is also helpful.
Excellent. Thank you so much, Dr. Safavi and Dr. Malik. Great additions. So now we're going to move to the third question, poll question. And the question is, when evaluating the PTV coverage using the CV-CHOP method, what is the acceptable percentage of the prescription dose that should cover the PTV? And the options are A, 90%, B, 95%, C, 98%, D, 100%. And the question is up.
So I have one question from the Anthony Paredes. For IMRT and BMAT, what's considered hotspots and cold spots?
If you wait after this question, we'll talk about the hotspots and
Okay.
what is the acceptable. So not to give it up yet. And cold spots, actually, you need to think how the cold spots are related with how much you are sparing some targets that they might be either abutting or overlapping with certain ORs. And I don't think there is a right and wrong answer on how cold something can be, but you need to make sure that the compromise you give between the coverage of the PTV and the sparing of that particular R, how important that is, and is maintained, basically. So, okay, we can end the poll. And so we have 83% of people selected option B, 95%, which is the correct. We always like to see the 95%, basically those cloud-wise, those covering the whole PTV. And that's standard everywhere. You might find little variation between centers because some centers, some institutions, they might have their own, maybe for whatever reason, coverage, basic percentage, acceptable coverage, but actually 95% is what widely has been used especially for head and neck cancer. Okay, so moving on to the age of the CV CHOP. Basically, this is about heterogeneity and hotspots. And this is basically to answer the question of, I think it was. So basically, you have to review the heterogeneity, and the maximum dose that we should be expecting for head and neck cases is around 115% of the prescription dose. And ideally, we like to have them on the GTVs that, I mean, again, whoever plans, you know how you can be chasing or hotspots everywhere, because you might put it somewhere and then you change something and it might go somewhere, or you try to reduce it in an area and then it appears in other areas. So you know, but actually it's very important to be thoughtful when you do your optimization, where to find them, and we want them in general on the GTVs or on the targets, if not possible, in the GTV. But 115% is the hotspot that we consider acceptable. And the cold spots should be normally, as you know, and I said a little before, they normally should be expected at the edge of the PTV, not in the GTV and not in the CTV. That's why we add the planning target volume, because the planning target volume is a structure that we add in order to also take into account difference in heterogeneity. But you want to make sure that your gross tumor disease and the clinical target volumes are very well covered. So that's one thing. And again, these depend on how close certain organ at risk are going to be to the targets. Anything
I'm just
to
going
add?
to quickly jump in. So Anthony Paredes asked 115% for 2 cc of PTV. And so this raises an important point that in our current treatment planning softwares, I think we're beginning to move towards reporting volumes, even for kind of what we typically in the past called point doses. So I think if your treatment planning software allows for a very small volume, this is kind of like your D.01 cc, the smallest kind of you can. If you have an older kind of like Pinnacle treatment software, then a D max or a point max of 115%. So the smallest possible volume receiving the highest dose.
Yeah, excellent comment. Yes, exactly. Perfect. Okay, so and we're going to move to the next letter of the CV CHOP. Is perfect. So the next one is the O from OARs. And again, this can be a very busy slide, but basically the OARs are a big part of the planning. And actually, this is what it drives the optimization on the planning sequence that you do during the whole thing, because you want to, as always, achieve the best coverage you can get to the PTVs or to the targets, and sparing the organ at risk that we have in the surrounding the targets. So basically, you always need to ask yourself, which organs are you especially trying to spare? So always start concentrating in the ones that are the most critical ones. For example, for head and neck, we always would think about the parotids, or any salivary gland, basically. Or for example, if you have disease in more, like the gross disease is more on the left side, you basically, okay, I know that my left parotid, let's say, or salivary glands on the left side, they're going to be more complicated to spare. So I'm going to try to do my best to spare more the one on the right, on the contralateral. So that's a concept that you want to have in mind when you are planning and when you are also reviewing the plan. Basically, when you look at the DVH, it will give you a great details of the minimum dose, maximum dose, mean doses for all the ORs and the PTV. And as we said before, very important to review the plan in 3D, basically in 3D, reviewing the isodose lines in every CT slice. And if it's a retreatment, this complicates things a little more. Basically, you need to consider a composite dose, and basically what priorities you can modify on the ORs in order to make it to account for the previous dose that patient received before. For example, especially for parts like core, brain stem, brain, esophagus, larynx, and the optics. Anything to add?
Yeah, I agree with everything. I would say, as the physicians that are, when you're contouring, one thing you're keeping in mind, you're already thinking ahead of the plan you're going to get on the other side, and being able to communicate to your entire team, like if you have a, for example, tumor that's invading the parotid gland or abutting the parotid gland, and you want to deposit 70 gray into that volume, you already know you're not going to be able to meet that constraint. And so having that understanding up front, don't try to, and your team will know this, that if you try to spare the parotid too hard on that case, your coverage will go down. So knowing which organs at risk you are going to compromise and what dose you can expect is also part of the evaluation of OARs. Just because something is not meeting your institutional constraint, maybe it's not possible to meet the constraint for this particular plan if you want to keep all your coverage. And so where do you make that trade-off for every single OAR? Of course, there's some cases where you don't, even though the tumor is, maybe close to the optic structures, in that case, you want to undercover in that area and prioritize OAR sparing because you don't want to have that risk of blindness. But in some select rare cases, if the tumor is lateralized and close to an optic nerve, and there could be a discussion with the patient that, if I put 70 gray here, then I will violate the constraint for that nerve. And maybe we go ahead with that understanding and you document that and you have a very detailed discussion. And so OARs in head and neck are such a long topic, and we can talk about this for so long, but it's always driven by this understanding between the patient and the physician about what exactly is the treatment aim we're both going for, and what are we expecting to protect, and what are we expecting to sacrifice, because the doses are very high. So when you evaluate the OARs, it's done with that in mind. And sometimes, not being able to meet the constraint is what you want. So it gets complicated.
I'll just jump in that a kind of summary statement for what Dr. Malik said, which actually comes from David Scher, is that the worst toxicity or complication of radiation is local recurrence. And I know that's not how many of us are trained, unfortunately, because we want to be very safe. And in many circumstances, we should be. But in head and neck and CNS, you're talking about very critical situations where local control is life and death, and where some of these OARs may need to be sacrificed, as Dr. Malik said, just doing it in a careful way. One quick comment I want to jump on before we go ahead is from Ana Peña about re-irradiation and possibly treating with different fractionations and how to evaluate the organ at risk doses. So this is where you really want to try to get access to the initial radiation plan if it wasn't at your center. You want to ask for all of the isodose lines to be overlaid in a deformable registration. So as accurately as possible, it's never 100%, but as accurately as possible, have all of the information simultaneously available. You want to convert everything to EQD2 equivalent dose in 2 fractions. So you can estimate the maximum point doses, volumetric doses, and then you can see how much more you can push some of these organs at risk. We don't have the best re-irradiation data yet. Dr. Malik is part of a working group that is helping to establish this, but you can try to look at the literature, see what the published reports are about increased rates of toxicity, and again, have an informed conversation with the patient documented. And in most cases, again, uncontrolled cancer is going to be worse in terms of toxicity and damage to those OARs, even than your irradiation being higher risk. So you do the best you can, use your clinical judgment, have all the technical tools, and try to help the patient.
Excellent. Thank you, Dr. Safavi and Dr. Malik. Great additions. So, and we are in the last letter of the perfect method, the CV shop, and which is the prescription. So basically here is when you need to make a pause and said, okay, you want to make sure that you review the prescription and dose per fraction for each dose level. Remember, for head and neck, it's very common that we might have different dose levels, targets that they go to different dose level. You want to make sure that we did not mix them up, and the targets that needs to be covered for that particular dose level is the isodose that is really covering. And it should be noted in the prescription and verified with the plan to make sure that it is consistent. So it's, the prescription is one of the third things actually for us that we ask to have right from the beginning, because we want all to be clear. And basically, you want to make sure that it's followed during the planning process and the evaluation process of the plan. Anything else from
No,
Dr. Malik?
that's great. Just knowing the dose levels used at your institutions and sticking to them, that helps a lot consistently.
Mm-hmm. Excellent. I mean, and I'm sure you all know, I mean, one thing that might help to actually make it easy is the naming. We didn't talk a little bit of the naming of with their naming conventions for targets and OARs for sure, but especially for target and especially for targets that they go through those to different dose levels. It's always nice to add the number, like the 70, 66 at the end of each of the targets. So PTV high / 70, something like that. So that, I mean, of course, it needs to be verified, but that actually will, when you're evaluated, it actually makes it a little easier just to turn on the right target and look at the correct isodose. And another important concept in head and neck planning is the use of bolus in the plans. So basically, if there is a need for using bolus, and this is something that is been done when gross tumor disease goes very close to the skin of the patient, so it's a good thing to use, and it's it's very common to have bolus in the patient. So it needs to be very clearly written in the prescription or in the plan what is the thickness that's going to be used and where exactly it's going to be placed on the mask. Actually, if normally these bolus are created in the in the treatment planning process in the treatment planning system, and then it's very important that the treatment planner or the physicist, whoever that's the setup check, goes to the machine the first day of treatment to verify that the bolus that is being created, it has been placed correctly on top of the mask of the patient. Good techniques are like when you go for the first day, you make some marks on the mask. So anything to help you to place that bolus consistently every day for all the fractions, because it's very important. Remember, this is gonna push the high dose closer to the skin in order to cover what needs to be covered. And if we place it in different areas, so we might be basically increasing the skin dose in areas that we do not want to. Dr. Malik or Dr. Safavi, anything on bolus or prescription?
Perfectly agree.
Perfect. Awesome. So we are moving to the question number 4. And the question is, in the CV-CHOP method, what is the maximum acceptable dose percentage for hotspots within the GTV? And A is 100%, B 110%, C 115%, D 120%. And the question is on.
El tercer pienso, pues para confirmar, ¿no? Validar y tener como más certeza de la forma.
So I have one question for the IMRT and BMAT. Do you have any recommend for the conformity index and the homogeneity index?
For head and neck, conformity index it's complicated to give recommendation because of the targets are very regular, and the dose distribution also are very, I don't want to say regular, but yeah, they confirm the regularity of the PTV. So there is not, I mean, particular, we do not follow any conform, we don't go through conform. We go through basically the isodose distribution. We look how they cover, and the DVH, 95% covering the targets, and the hotspot 115. So I don't know if Dr. Malik of Dr. Safavi, if you have used this concept of conformity on head and neck cases.
No, not for head and neck, primarily for like intracranial SRS and for lung SBRT.
Yeah, which most of the lesions are very, spherical or easy in a way. Like we said here, they can be, the shapes of the PTVs can be very, different. So it's complicated to come up with a number. Okay, so we can end the poll. So we have a good amount of people responding, and 71% of the audience chose number C, which it was marked there. So that's good too. So 115%, which is the correct. We were talking about that for head and neck. Is very, very common that 115 is what everybody is widely using as a hotspot. Having said that, and hopefully you agree too, Dr. Malik and Dr. Safavi, there are some situations when they're, like, for example, I will always say for nasopharynx cases that we might go a little higher, but you need to also have a discussion with between physics and physician where that, let's say if it's 117, where is it? If it's too close to certain organs at risk that we're gonna do some damage. So we might accept a little more than 115, but you want to have, of course, limits on that as well. Very nice. So then these next two slices is, again, these are the five most common mistakes that they are found while evaluating head and neck plan. And again, they might not be the only ones. They might, I'm sure you can find other things but these are the most common that we have seen. And number one is that, for example, something that is being found that not all the GTVs were contours, not all the GTVs have the appropriate expansion. That's something that is very critical. If we found that, we need to make sure that our target cross tumor volumes are very well contoured, and they are contoured. Whatever you need to define as GTV, it needs to be in the planning, and the expansions needs to be. Not all the PTV 70 targets were covered with the 70 isodose line, especially when there were multiple 70 targets drawn, PTV 70. That's something that is being, like, for example, we might find out when there are like nodes or little pieces that can go to 70, and then for whatever reason, one was missed. And so that's what is very important. And as we said before, to evaluate the isodose clause for each dose level in every single slice, because you will be, and also turning on the correct targets when you're evaluating on the treatment planning system. So basically, also something that has been found is new planning directives were added verbally after the planning was complete. For example, someone can say, oh, can we take off the dose from here, move it here, for example, the mandible. So you need to make sure that planners know everything that they want to know before starting the planning. Of course, things, there is always a discussion and things can be changed. That's totally allowed. But if you have things in mind and you can make things more standard, everything should be communicated in advance. So if you have something in mind that is particular for a case, that avoids something that is not on the standard, you need to tell them, because if you don't tell them, the planners won't know. The planners will assume that we are doing this as a regular planning process. So, and discussing every single detail with the planners before the planning. For example, carve out PTV from where you don't want those is a very important aspect. And basically, this can be missed if you don't communicate that. That's what we said. These planning directives specific for that patient, they need to be verbally communicated. Number 4, thinking that a plan is finished when it meets all the or those constraints that's not enough. Basically, that could be a mistake. Don't just beat it. Actually, that's a concept that applies for every single type, not only for head and neck. Just because we got the parodies mean those less than 26, both of them, they're both 25.99. It means that was the best you could have done it. If you can basically reduce or spare the parodies, I'm talking about the parodies as an example, more maintaining the coverage that you want without compromising coverage, then you do that. Remember, we always like to think about the ALARA concept, as low as reasonable, achievable. That's a concept that needs to be in the minds of everyone. We want to remember, we don't know what's going to happen with this patient. The patient might come back. And also, those are limits that they are established for many reasons, but if it can be lower, it's better.
Yeah, this is one of Dr. Malik and I's favorite topics, which is pushing the optimizer as much as possible and really thinking every single individual plan is different, and IMRT allows this. Adaptive radiation in the future will allow us to do this even fraction by fraction. We need to think about as high in the target as possible, as low to the OARs as possible, and not just follow our institutional guidelines. When IMRT started, we needed to have some kind of common ground and basic instructions. And so it was great that 20 years ago we followed those recipes to be safe. But 20 years later, a lot of people are just following those same recipes and making sure there's a check mark. But we need to push more. We're technical artists as radiation oncologists, and we need to push that. As Dr. Lee would say, we shouldn't just treat by coloring book.
Yeah, exactly. Excellent comment. Thank you. And the last common mistake is, we talk about a lot about the shoulders, is basically when you see that something is going through the shoulder for fixed beam IMRT plan. And I also want to make sure that it's also, this apply for VMAT. Also the VMAT concept, when you do full arcs, you need to make sure that you did not, that you spare them. If the beam goes through the shoulder, the calculation will be off. It is very important to avoid with IMRT, especially because remember, IMRT, the beam doesn't move. So with VMAT, it's a little more permissive because it goes through. But IMRT, you will be giving that beam that goes through the shoulder the whole number of mu, and the calculation will be off. And having said that, we have the Zoom poll question number 5. Anything, before I go here, anything that, another common mistake that Dr. Malik or Dr. Safavi that you might think?
One quick, oh, go ahead, Dr. Malik.
No, just gonna say the simple ones like labeling, patient identification, dose, site being treated. You just want to make sure that when you're doing your contour review, plan review, that everything does match up with the clinical history really well. Sometimes, you want to, when you're reviewing the contours, they may look okay, but do they match this patient's clinical history? Like what levels were dissected? Are you covering those levels? Otherwise, a plan could be, the contours and plan could look perfect for one patient, but for the next patient with a different medical history, a different nuance, those contours won't work anymore. So it takes a lot of like going back and forth to the patient's medical chart, making sure everything matches up right away, because correcting those kind of things partway through is very, very tedious and sometimes not possible. So better to just, sit down and dedicate a lot of time to making sure that you have everything right before you approve the plan.
I completely agree with Dr. Malik, and one kind of modification that I made personally to CB CHOP in the last year or so has been to expand the acronym for myself to film CB CHOP. So when you're evaluating the plan, look at the fusion, right? The contours may look perfect on the planning CT based on some assumptions, but if the fusion with the PET, with the MRI that you have used to contour is not necessarily right, you could be missing your disease. That's clinically apparent. As Dr. Malik said, patient identification, the laterality in some cases, and then the medical history, as Dr. Malik was saying, going back and forth to the operative note, to the physical exam. Documenting the physical exam, Dr. Malik and I were both trained very meticulously to document, almost better than the surgeons, because we have to really know where this disease is going on a CT, which is all gray. The surgeon can still make judgment calls in real time. So knowing exactly, was there some mucosal abnormality going on to the pterygomandibular raphe? Was there some nodularity when you examined with your finger on the glossotonsillar sulcus or base of tongue? That can help you to make judgment calls when you're contouring. So the film CB CHOP gives you the most comprehensive approach for evaluating.
Excellent. Thank you, Dr. Malik and Dr. Safavi. See, that we can always make it more perfect, the CB CHOP method. So this is a amazing feedback and concept that you have added. Very good. So we can go to question number 5. which organ should be contoured to extend 1 cm past the most inferior PTV for accurate mean dose evaluation. And A is the spinal cord, B, the esophagus, C, brainstem, D, larynx.
I have one question. The 50% isodose curve, how many centimeters of the PTV must fall?
I can start with the answer, and then Dr. Malik and Dr. Safavi, you can add. I mean, 50% of the isodose, what in head and neck particular, we want it to be as conformal as possible, following the shape of the PTVs. But for IMRT cases, actually 50%, you might start having some streaking, especially in the area of the parotids or the oral cavity, which is organs that we spare with mean dose. So basically, I don't think we do have, again, a centimeter, a precise centimeter margin, but in areas that is very homogeneous, I will say that the 50% should follow the shape of the PTV as close as possible within, I would say, within 1 to 2 centimeters, because physically that's possible. Less than that, it will become an SBRT plan, which is not the case here.
I agree. Yeah.
Very good. So we're gonna allow, and again, remember the question is for mean dose, accurate mean dose to the organ. We can end the poll. Yes, indeed. And every 47% reply esophagus, which is the correct answer, because this is the esophagus is the organ that we will be looking at a mean dose or a volumetric dose constraints. Remember, the spinal cord, brainstem, the larynx, we look at maximum doses. So that's why it's very important when you define the organs that you're looking at mean dose, that you have that consistent 1 cm expansion most inferior of the PTV, because just to make sure that the volume of the structure, because the esophagus might continue, but you want to be consistent in that volume that is being contoured. That's perfect. So, and some tips that we can give you for evaluating plan. So basically, when you open the plan, sometimes it helps to simplify. So make sure when you see, for example, here we have an image that is nice, it's colorful, but there are many things going on. So you want to make sure when you are opening the plan, you said, okay, let me look at how the PTV 70s are covered. So just put them on and just type either the isodose, this line, or the cloud, that 70, look at that, and then start adding things. Like, for example, if it's close to the parotids and you see that the 70s, that you want to see that the doses are going a little on, and it's because the parotids are around there and you're trying to spare them. So make sure that you have a consistent, simplified methods to evaluate the plan. Don't put everything and all on, because isodose lines, they might be mistaken with contours, the color. People have used different colors that they're used to, so it might not work for you. So make sure that also works for you. And other thing is like basically missing the gross lymph node is very important. You can see here on the picture. See, for example, on the picture on the left, you have everything on. You might not even notice that was missed, because there is isodose around, there's colors and everything, so you might not notice. But then it's very clear on the picture on the right that node was not included in that PTV. So that's very important. That's what simplifying is also an important concept. And as I said before, always look at one thing at the time systematically. So make sure that when you evaluate head and neck plans, you have a method and you go through whatever you define as your method, that you go and you systematically go through all the steps and all the things that you want to check systematically. Anything that you would like to add?
No, that's great.
And we can move to I think this is the last question that we have, poll question. And the question is, which of the following is a common mistake when planning radiotherapy using the CV-CHOP method? A, using too many VMAT arcs. B, not all GTVs are contoured appropriately. C, over reducing the PTV margins. And D, prioritizing those homogeneated over coverage. Also, we always encourage everyone to answer. In the meantime, if there is any question, now, well, we can maybe go through.
Maybe we have a question from a bolus. If you consider a bolus inside the patient, or you need to contour, what do you recommend? To put the bolus in the CT, or drawing in the Ternary plan? Yeah.
That's a good. I mean, if I think that probably Dr. Safavi and Dr. Malik, if you know where the area where you need to bolus is good, it's good to simulate the patient with the bolus on. That will solve a lot of problems because it's there, clear. It will come up on the CT images. It's very easy for us. But it might happen that if you miss a couple of slices, we might need to extend it, and that's possible too. So it depends the situation. Most probably is that the bolus is going to be placed on the treatment planning system with a decision, okay, this is the area that I need to bolus after you have all your GTVs and PTV contours.
Yeah. I think it's what your team is most comfortable with and happy with. We here in our practice, as you say, we kind of put it in the treatment planning system and do it afterwards, and everyone seems to be happy with that approach, but we always have the option of including it in the simulation if we feel that will help. So maybe you can try both approaches at your center and see which one works for you better.
Yeah. So we're going to end the poll, and the majority, 48%, responded option B, which is not all GTVs are contoured appropriately. Remember, we emphasize that. Make sure that all your GTVs are contoured, and going beyond that, they have the right expansions as well. This is the reference of the CB-CHOP method, the paper when it was published in 2017. And then as a summary, we can say that establish a perfect method for evaluation, plan evaluation. Basically, that's what these CB-CHOP methods was created. But of course, we just learned today that you can always add a little more letter. Like I like the concept that Dr. Safavi introduced about the filmed CB-CHOP. That's very important. Actually, I do agree with that. A good image registration that guides you to do the contouring of the target is very, very important. And that's before we start contouring. So, and plan evaluation is a very important step in radiotherapy. And if you stick to a systematic method, you can improve the quality of the treatment of your patients and decrease the chance for accidentally missing something. And of course, the more you practice is the best, as the best you're going to get in plan evaluation. So always practice, and the more plans you review, and I always insist develop your systematic method is very important. We can tell you, okay, this is what you should follow, but it needs to make sense to you, and you need to systematically apply it, whatever method you choose. Now we're going to go through some practice cases. I don't know if you want to add anything before we go to the practice cases.
Oh, let's do it.
Okay, let's do it. Awesome. So you're
okay.
I'm going to start.
I will share my screen.
Yeah, perfect.
And let's walk through using this method. I don't think we have a lot of time remaining, so I'll go through this in a little bit fast, and then Dr. Safavi also has a case for us. So let's just practice. This is an anonymized patient. It's a nasopharynx case. And, using the film CB-CHOP method, we have our fusions down below. So this is our primary CT simulation scan on the left side. And on the right side, we have all these, we can pull up any of the fusions for comparison. And so we can see that it's fused correctly to where the disease is. You can see that lighting up on our scan. So the patient's, first thing you would do is, let me just move this. So you check your fusions, patient identification, clinical history. And this patient's clinical history is that they had a locally advanced nasopharynx cancer. They got induction chemotherapy, and now they're going for chemoradiation. So some of these scans are done before the induction chemotherapy started. So you'll see there's a lot of tumor bulk there, which isn't there anymore. And that's kind of what we expect to see. That's the tumor response, but we're still going to cover this area to 70 gray. So just making sure all of our fusions line up, which will help us contour, because in nasopharynx cases, MR and PET scans are very helpful in delineating our volume. Prescription, patient identification, all of that. So we have all that done. So let's do contours first, okay? So we'll start off with a primary GTPY, which is the label that we have gone with here to just state that, this is post chemotherapy GTV. This is what's remaining, and that's what's been contoured. And if we're happy with that, and let's say in this case we have some of that disease going into the clivus, and so we've included that. And this here is going to be the pre-chemotherapy GTV, which we use this MRI fusion to assist with. So it's very important, again, as we said, to have good diagnostic imaging available to us to help see this kind of tumor extends into the parapharyngeal space almost. And as we go down, and you have here, it's kind of encroaching on the pterygoids. So we need to cover all of that as our initial kind of pre-chemotherapy GTV and pre-chemotherapy nodes. So we're just going to go one by one, make sure that everything was contoured and we're happy with that. And you can even go through, switch back and forth between the PET scan, the MRI, and just be confident and reassure yourself that all of the disease is contoured and covered. So then we talked about the expansions. So these lymph nodes that are contoured do have expansions. And then again, we have our lower dose 56 gray. Let me just turn on all of this so we can appreciate that. So our final volume will kind of look like this. We have our CTV primary 56. It covers the posterior maxillary sinuses and our typical kind of nasopharynx guidelines. And remember, we talked about looking at all the planes. So we're going to change to the coronal plane, and it's very important here that, let me switch back to the MRI just for clarity. In nasopharynx cases, we have our guidelines state that we need to cover certain foramina up to the skull base, rotundum ovale. And so in the coronal, we're able to see that we're contouring all the way up to the skull base. And that's very important because there was disease that extended quite close up there. And so that volume needs to be covered. So coronal lets us appreciate that much better. And on the sagittal, again, here I'm looking to see if we're coming off of that uvula, soft palate, and oral tongue, because we know with this case, the disease is going to be mostly posteriorly and extending downwards along the nasopharynx and oropharynx. This tumor was quite large. So just making sure it makes sense in 3D. So we have our contours, and then you can turn on your organs at risk just in that's a lot of them, but just in the portion of contour review. We'll get back to the doses later on in the method, but just going through them one by one. And because of time, I'm not going to have the time to go through all of them, but essentially you need to turn on all of your OARs and make sure that they're all contoured, the esophagus, the cochlea, everything basically in the head and neck region. So that's C. Next, we'll go to beams in the interest of time and making sure we understand the type of plan that we've been given. So here it's a 2-arc VMAT plan. You can see the rotation, gantry start, gantry stops. It's 2 full arcs. You can even, if your treatment planning system allows you to do, you could scroll through the arcs and you can appreciate kind of how the arc is delivering kind of all the monitor units in kind of a, spatially how that dose is being delivered and making sure that this is exactly what you want. So if you're happy with this, then you go on to the next step. So I'm just going to walk you all through this. So we had contours, beam, and next we're going to do coverage. And here we can go to plan evaluation and assess for coverage. So we have our clinical goals here. We have our prescription listed above. And so we want to make sure our PTV coverage is 95%. The 56 is covered enough. And then the high dose is also covered. And for that, let's go to dose statistics. And we do see our, I'm going to open up, turn on the PTV here. There we go. And so we just want to make sure that our, we have enough coverage here, which it looks like we do. It's not listed here in the clinical goals, so I'm just using it in the dose statistics. And if you're happy with that coverage, you'd evaluate your OAR doses to make sure that your chiasm is spared appropriately, and your lenses dose you're happy with, and based on where the location of the tumor is, what you would expect all the other OARs to get. So you can see the left parotid is not meeting the constraint; it's a little bit higher. So you would kind of try to understand why that's the case. And in this case, given where our tumor is and the way the volume was extending, you can appreciate why the left parotid dose would be a little bit higher than the right parotid, just because the disease extends more so on this side. So let's just say, again, in the interest of time, we're happy with this. We go on to assess heterogeneity. And again, we look at, for this part, localize our max dose. So we have 7404, which is less than 115% that we discussed. So we're happy with that. And when we look at our cool spots, and for that, you can see anything here that's below 95 and all of these other colors. We're just going to go through to make sure that all of the areas that are not our prescription dose, that are less, are not going to be within our PTV. So you just go through again, all the way from top to bottom. You have to scroll through the entire plan and convince yourself that this is exactly what you want, and it's an optimized plan. And you do the same thing on coronal, and you do the same thing on sagittal. And if you're happy with that, then you move on to the next step, which is, again, this time looking at the OARs. We did that a little bit out of turn, and then the prescription. So we're happy with the prescription. We confirmed it's 70 gray, and then we looked at the OARs, and we saw that which ones are being overdosed, which ones are meeting constraints, and then we're overall happy with this plan to move ahead. So then I'll let my planners know that here there's no changes recommended. We can proceed with publishing the plan. So that's a brief overview. I'm just going to stop sharing and hand it off to Dr. Safavi in the brief time we have left. I think you're muted right now.
Can you hear me now?
Yeah.
Great, thanks.
Yeah.
So I will also be presenting a nasopharynx case, this one even a little bit more advanced in terms of disease bulk than Dr. Malik's. In this case, it was contoured on a different planning system, and so that was not anonymized. So I will be showing you a video of the contours before we look at the plan itself. So here first, again, the image fusion, I made sure to verify that everything has been fused carefully. And in a nasopharynx case, as Dr. Malik said, if it's post-induction, EBV positive, you have a lot of data sets. You have pre-chemo and post-chemo. So you want to interrogate each one of them closely for the fusion, make sure it's accurate. And you want to make sure you have multimodality imaging. So here I have a PET scan on the screen right, but MRI is crucial for nasopharynx as well, given the skull base involvement. PET scan will often undercall the skull base involvement because of how close it gets to the brain and the high signal from the brain. So you want all of those imaging. Here I'm showing you on the right the pre-chemo PET scan, and on the image left, you are seeing the simulation scan. So again, like Dr. Malik's case, you want to make sure, I'll pause here, that your contours are accurate. You want to make sure your elective contours for nasopharynx are very important. So you're covering the posterior third here on the slice of the maxillary sinuses. You're covering the posterior third of the nasal canal. You're covering your lacerum, your foramen ovale. You're covering your pterygoids. You're covering your pterygopalatine fossa. In this case, there was disease involving the clivus and the petrous bone. And so you had to go all the way to the edge of the bone here with the GTV in red. As you'll notice on the PET scan here, even pre-chemo, you can't really appreciate that bony involvement. So that's why the MRI was crucial. Continuing on with the video, you see very bulky disease. It's heading into the foramen magnum, into the perivertebral musculature, large neck disease engulfing part of the parotid with direct extension, submandibular disease. This patient even had disease going back behind the trapezius. There was also a target in the axilla here. So very extensive disease. So review those carefully. I'll pause the video here. At Princess Margaret, where Dr. Malik works and where I trained, we are very meticulous with our contouring. So we label every structure, pre-chemo, post-chemo, GTV, CTV. Other centers are not as meticulous, and I think they enjoy much faster contouring than Princess Margaret, but there is some method to the madness and it can be enjoyable. So I did this contour recently. Now let's look at the plan. So this patient is being treated with protons, so a little bit different, and to give you a bit of familiarity with how things may look. So let me just move the zoom bar across. Good. So let's look at the patient modeling. So this is a composite of the CTV low dose because we're going to be treating this patient with a two-phase sequential plan. So we're first starting off with treating the low dose 50 gray. If you do simultaneous planning, that would be your 54 or 56 gray volume. And then because we anticipate a bit of disease response and we want to reduce toxicity, we're going to replan him and then treat him up to 70 gray to the gross disease targets, again, with protons. And then we want to turn on our organs at risk. So some of them have been turned on. I'm going to turn them all on now. So here, when I was reviewing this plan, as I mentioned before, I'm a little nitpicky with my parodids. I don't feel these have gone medial enough. So I've asked my proton center therapist to put on these OARs to change this. As well, you'll see on this side, the parotid is going more anterior to include the duct. Here it's not, so I asked them to improve that as well. The oral cavity, I think, the floor of mouth could have been contoured better, so I've asked them to modify that as well. Going high up, I noticed with my OARs that there's just a little few slices of the optic nerves that were not well contoured. Is this going to be relevant for this case? Not really, but we better be consistent. So little changes like that, always good to critique for the organs at risk. The most critical ones for a case like this are the brain stem. So let us just quickly look at this on brain window. So we're going to go here. So again, you want to make sure that things have been contoured well. So again, we have this Mickey Mouse appearance to the midbrain, prostate-esque appearance to the pons, and a nice circular appearance down at the medulla. So I'm happy with our brainstem, which is a critical organ, considering how close our target volume comes to. So we do that. I'm going to switch back to the soft tissue window. Good. And now, as Dr. Malik did, I'm going to go to the plan design. And so with protons, they can be treated in different techniques, uniform distributions, optimized distributions. And so this is a multi-field optimization method for planning. So you'll see that there's beams coming from these different angle points. And so one reason why you should check the beams in this kind of case with protons, and we'll take a look at the plan in a second, is the entrance dose. So the entrance dose with protons is higher, and so it can be harder to achieve the skin sparing effect that we see with IMRT photons. And so the more beams we have, there's more areas that are going to have entrance dose to the skin. So keep that in mind. So now let's go to the plan evaluation. And so as Dr. Biancia has said, we're going to turn everything off just to make it a little easier to look at things and selectively turn on structures. So I'm going to now turn off all of the OARs for now. So we have our CTV on, and I'm going to turn on my prescription 50 gray for the low dose, as well as the 95% at this point. I'm going to blow this up, and we're going to see the doses are now in the washes, the contours in the line, just to see how things are well covered. So up here, we see we have a bit of under coverage laterally. This is because we're trying to protect the temporal bone, the temporal lobe. So it's pushing the coverage a little bit laterally, but that's okay. We keep scrolling through. This slice here represents my point about inaccuracies in contouring and in interpolation. So this is a slice where if you look in isolation, you would be worried about coverage, but when you look at the slice above and below, it's fine. So always important to scroll through every slice. Again, here we're trying to protect brainstem, so a little bit of under coverage. So that's to be expected. So as we see, the coverage of the CTV qualitatively is fairly good. We're now going to take a look at our quantitative clinical goals. So when we come down here to the CTV, one other comment for proton plans, there really isn't this concept of a PTV. You contour a CTV, And then the planners will do this concept of robust optimization. So you plan still to this CTV in essence. And you see that here, 95% of the volume, getting at least 95% of the dose has been exceeded. This should be in an IMRT plan higher, but for protons, this is how they plan it. And then at least the prescription dose to 95% of the volume. This one is a little borderline, but again, because of all the volume that's going close to critical organs. And as Dr. Malik said, we're going to take a look across all three views just to make sure everything makes sense. All the important structures are well covered. Again, as Dr. Malik said, you want to look at the soft palate involvement and all of that. Make sure your field has gone superiorly enough into the sphenoid sinus. And coronally as well. It helps you to evaluate the skull base coverage. So this is excellent. It's pretty good. It's going pretty lateral. So pretty happy with that. Now, one instructive difference is to look at the entrance doses, as I said. So take a look at here with this proton plan. Yellow is 95% and it's going right up against the skin. The reason for that is because there was bulky target and clinical target volume here, and proton struggles with the skin sparing effect. So for this patient, I would expect to remember on treatment to keep an eye on their skin posteriorly on the ipsilateral side. On the elective, it's done a good job, fairly similar to IMRT, of pushing the dose away from the skin, but here it was too hard to do that. And then another difference is if you look at the lower isodose lines, so 25 gray here is the 50% of our prescription, 50 for the first phase. You see the nice sparing of the oral cavity that proton allows. In Dr. Malik's plan, it was going a little bit more bowing in the 50%, frying those taste buds, but with proton, it's pretty conformal. And then also down here, you see that the midline sparing is quite excellent. So as you get lower down, the esophagus really isn't getting much of any of this 50%. So that's really good. And it's harder to achieve that with IMRT. You then go through and look at the hotspots. So for this, I'm going to also qualitatively appraise, not just look at the max point. So I'm going to turn on the isodose lines higher than 50. And I want to make sure they're all within where the gross tumor is. And in this case, it's a pretty homogeneous plan. I see a little bit here in the clivus of pink, little dots here and there. So this is a very homogeneous plan, not too hot, which makes sense given all the organs at risk. The max point here is 53.25. So just a little bit above 105%, certainly not 110 or 115%. So a cool plan. That's important because Dr. Nancy Lee's group has published on some concern for osteoradian necrosis in the mandible. So we've been trying to cool these plans. Okay. And then let's now look at our organs at risk. Let's turn some of them on. Plexus is important for this case, submandibulars, parotids, esophagus, mandible, cavity, brainstem, brain, spine. So again, we see that we have really good, I'll turn this off, really good bending with the proton of dose away from the brainstem. Even though the clivus was involved and our target volume is going all the way there, the 95% is coming nowhere near our brainstem. So this is really excellent. You look at the parotids as well, and only a sliver is getting 50% of the dose in blue on the contralateral side. So this has been spared very well, and I'm happy with how well this has been pushed. The ipsilateral is unsalvageable. You have gross disease coming all the way up. So as Dr. Malik said, you tell the patient you're going to have fairly dry mouth because of loss of function on this side. And so that's unavoidable given what we need to treat. Another important point which applies to IMRT and protons is the cord. So at really good centers, Princess Margaret, Memorial Sloan Kettering, you want to keep the dose really strongly off the spinal canal. So in a 70 gray plan, ultimately, you should really not have more than a D max of like 35 gray to your spinal cord. You really want to aggressively push this, and I encourage you to do this to your centers too. So in this plan that's gone up to 50, 25 is nicely off the cord. So I expect when we go to 70, we'll still be able to keep this off 35. Just because published constraints for the cord are 50, 48, 45, doesn't mean that in this plan you can't push it to achieve it. So in head and neck plans, forget what's been published. You want to push to below 35 if you can, which is what our centers try to do. So I'm happy with the cord. I was happy with the brainstem. Brachial plexus, as you see, it's coursing right through this high-risk volume, so it's not going to be spared, unfortunately, and it is what it is for this case. Quantitatively, we look through as well. We see brachial plexus is below our constraint of 66, which is going to be used for the total plan. I expect we're going to exceed this once we go to 70 gray for the second phase of the plan, especially on the right side, but it is what it is. Again, mandible, it's already starting to get a little high. So 50 gray was our prescription for this phase. We've already exceeded. So we're going to have to see if we can try to keep this as close to 70 as we can when we boost it. The parotids, again, were already far exceeded on the right as we expected qualitatively. Submandibular gland ipsilateral is also getting fried, but unavoidable. The organs at risk we've evaluated. And then the last part, the P, you want to review the prescription. So for this first phase, 50 gray radiobiological equivalent and 25 fractions. So other than the organs at risk, which I asked the planner to fix, I was generally happy with this plan. So we'll do the first phase, hopefully achieve a clinical response, and then replan him for the second phase to 70 gray.